Well, good morning. It's 9:30 and welcome to the first Health Overview and Scrutiny Committee of the year. Now, apparently it's fallen to me to kick the proceedings into place, and the first item on the agenda is the election of chairman for the following year.
I propose Councillor Davis as chairman of the committee.
Okay, so Councillor Davis.
Sorry, Gordon, I've just said, we had a conversation, I decided not to stand. I'd rather you didn't put me forward, thank you.
Right, in the light of that, are there any other nominations?
Chairman, I'd like to nominate Councillor Billsborough.
Okay.
I would be happy to second that.
So there's been Councillor Billsborough has been nominated and seconded. Are there any other nominations? Well, I think we should take a vote then. All those in favour? I don't do against. Do we do abstentions? Well, I'll hand the reins over to you then, Gordon. Okay, thank you. Means I could have your seat for once.
Right, thank you for electing me. I'll try and justify your confidence. I only found out about 5 minutes ago that this might happen. But anyway, I would like to thank Councillor Davis for his services during the time he's been chairman of this committee, which I think is for 3 years. Can we move on to item 2, please? Election of vice chairman.
The proposed Councillor Nellams, chairman.
I'll second that.
Any other nominations? Those in favour of Councillor Nellams as vice chair, please show. Anybody against? Any abstentions? Councillor Nellams, you're elected. Welcome. Right, item 3, declarations of interest. Any members wish to declare an interest? Councillor Bennett. Sorry?
Chairman, I am the Council's representative on the shadow governing body of the Royal Cornwall Hospitals Trust. And I do believe that understanding the disqualification of the similar position from the Cornwall Partnership Trust from this committee, I would like it looked at to see whether I am a legitimate member of this board.
Thank you. Councillor Saville.
Can I declare a non-disposable interest, disclosable interest, as current chairman of the Children's and Young People's Committee?
Thank you. Councillor Davis. I will declare an interest. I am a director of Health Watch. It's a non-pecuniary interest, and my daughter is also a staff nurse at the hospital. Right, we'll move on to item 4. Minutes of the last meeting, which was on the 23rd of September. May I have your wishes? Councillor Daly.
Chairman, on page 2, at the top, it says the minutes of the Health Overview and Scrutiny Committee of date, nothing else. Does it mean they were approved or not approved?
At the top of page 2, resolve that yes.
Chairman, yeah, that was.
I can't recall. I can't recall. It was made in 2014. Andy.
Chairman, that would just be a typo. Yeah, it would go on to say that the minutes of the Health Overview and Scrutiny Committee of 15th of May 2014 be considered a correct record and be signed by the chairman, is what it should say.
All right, thank you. In that case, may I have your wishes on approval of the minutes? Are you willing to accept the minutes of that meeting? Those in favour, please show. Anybody against? They're carried. Now we move on to item 5, there's an urgent item which has been put around the table. I do not like items put around the table, so I should like to know the reason why was such short notice.
Chairman, this was reported to myself and the ex-chairman of HOSC last week.
Yes.
So that's why it's an urgent item, in that we didn't have time. It was after the deadline to get the papers in. Yes. It's been passed from Health Watch that they have actually reported this back to SWAST, but there's been not a...
We didn't make the referral to HOSC. That came from a councillor, as I understand.
Say again, sorry?
We didn't refer this matter as an urgent item.
Another councillor referred that to us.
Yes.
We did some investigation and found out that Health Watch have reported this to SWAST and had a not exactly brilliant response from SWAST. So we thought it'd be appropriate to bring it up in this arena for us to have a look at this issue and see whether we can get any further with the issue. Sorry.
Yes.
Is that better? So we thought there hasn't been enough forward momentum with this issue, so we would bring it up in HOSC and see if we can get a more better resolution for the islands and for the co-responders.
I see. And you're proposing that HOSC investigates this?
Correct, yeah. And they report back to the next committee.
And when is the deadline, or when would you want the deadline to be?
I'd like to happen as soon as possible. There's issues with staffing, with people booking on and off of the system, which might lead to no cover on the system. And there's also issues with reception of the pages as well, leading to calls not being answered. So I think it's quite an urgent item.
Could I? Yes. Councillor Davis.
Oh, thank you, Mr. Chairman. Whilst fully acknowledging that this issue had been brought to my attention when I was chairman of this committee, this is the first I have heard of a single issue group being formed. I'd just like to make that correction. This was never put forward to me in those words.
Yes.
It was an issue which I had an email from Health Watch last night. But obviously, knowing that I was not prepared to stand, I was not in a position to do anything about this at that point. I realise it's an issue, but I felt it was obviously something that should be discussed under urgent items. But as I say, I wasn't aware that it was suggested to make a single issue group at this point.
Well, thank you, Councillor Bennett.
Chairman, I think it's a very important issue, but I don't think the way to address it is by the creation of a single issue group. I would have thought that it could have been dealt with perfectly, adequately and efficiently by the officer in charge phoning the relevant people on the off-islands in particular, where I understand there have been problems, writing a report quickly and getting the results to members of this committee and to those who can affect some change. While we're sitting here with a single issue group debating it, there can be an issue when it's a matter of life and death, pages don't go off and somebody's life is lost. And I just think let's deal with it. It could be dealt with, quite frankly, within a day of good communication.
Councillor Sims.
I was more or less going to say what you just said, but just as a... What is SWAST? What does it stand for?
Southwest Ambulance.
Okay, I just think it's a fairly good idea. If you do have acronyms there, just at one point have them bracketed so we know what they are. Thank you.
Councillor Saville.
Chairman, this is an urgent item and I commend the officer for bringing it to this committee. I think initially we can go down the line that Councillor Bennett has suggested, but if there is no response from SWAS within a reasonable time, I do think we ought to actually establish a single panel, because we can demand that they actually are present in this chamber and are answerable to us. And that makes a whole lot of difference, rather than having the odd letter from somebody, from the Council of the Isles of Scilly. When they're actually sitting in this chamber and facing this, a single issue panel, and we have every right to demand they do. I hope it doesn't come to that, but this is a pager system across the whole, not just for the Isles of Scilly, it's across the board. So it's just not working here. So I think we have to be prepared to establish a single issue panel to achieve what we need to achieve. But I'm willing to support the first recommendation that a letter is written. But I would hope that the local people, the co-responders, our local ambulance people will actually have already pointed this out to their superiors. I don't know if they have, but I would hope they had. So we might actually come down to a single issue.
Yeah, I was under the impression the issues had been reported already. That's exactly what it is. Gathering the evidence together, we need to have firm evidential backing for our letter. So gathering that together and then writing a letter or forming a group to write that letter, send that back. If we get no response, then we get them over here to take them to task.
Councillor Davis.
Thank you, Mr. Chairman. I understand and agree with what Councillor Saville says. She makes a very good point. But I would agree firstly with Councillor Bennett. I think that we're in danger of crying wolf and rushing into these committees and start setting up talking shops. This sort of matter should be sorted by a personal view, and if it's not sorted on the normal channels, it shows that there's perhaps something else seriously wrong. I quite agree that a letter, I would suggest, or make a proposal even, that a letter is written that this matter should be sorted out, and then if we get no answer, as Councillor Bennett quite rightly says, then we should proceed to a single issue group.
What I'm going to suggest is that I think that the matter should be delegated to the chairman and vice chair of this committee to work in conjunction with the officers concerned to make sure that action is carried out promptly. If that would, we will take responsibility for doing that.
The letter should come from yourself, Chairman.
Pardon?
The letter should be signed by yourself as chairman of this committee.
Yes.
You've got the... Yes.
Yes. And then it's the members responsible, heads who will roar if it's not done. If that is your wish, I'm prepared to ensure that action is taken promptly. Councillor Davis, do you want to speak in?
If that's a proposal, I would second it.
Can I just add, how long, if we don't get a response from SWAST, how long are we waiting before we form a single issue group? And do we wait for the next meeting, or do we have a special meeting?
Councillor Sims.
Could we not cover all the bases and make yourself and Mike the single issue group? Then it all happens in one hit.
Well, I was suggesting the chairman and the vice chairman, which is often what we do when we have this kind of situation. But I'm more than happy if any other councillor wishes to join this small band to ensure that action is taken. Yes, vice chairman, sorry.
Yeah. Yes, Chair, I think you're right. I think a letter comes from you with my name attached, and if nothing happens, we chase it up straight away.
I would say if we don't hear within a week, the sparks will fly. Jane?
Could I just ask that you keep Healthwatch informed as well, please?
Yes, Healthwatch must be kept informed. This is a matter of urgency. It will be done if that is your wish. Councillor Saville?
I got the impression that there was a recommendation that even if we go to a single issue panel, it would only be yourself and your vice chairman. I don't think that is right at all. Other members should be involved. Healthwatch should be involved. They will have a significant amount of the evidence.
I'm quite prepared for anybody else to join us on this. A small group, it can include Healthwatch, it can include off-hours like Councillor Bennett. All I'm saying is it needs member leadership to enforce it. And I'd be quite happy for anybody else to join us. Councillor Bennett, you wish to speak?
Chairman, yes, I think before the creation of another group, I think that a telephone call from yourself to the chairman of SWAST might be helpful.
Excellent idea. Right. Any further comments? Is it your wish then that it's delegated to the chairman and vice chairman of the committee and anybody else who can clear up this mess to take it on? Is that your wish? Anybody against? Right, that is carried. Right, we'll move on to item 8 now. Presentation of quality accounts, Peninsula Community Health.
Item 6.
6, I'm sorry.
Thank you, Chairman.
Yes, go ahead.
For those of you who don't know me, I'm Steve Jenkin. I'm the Chief Executive of Peninsula Community Health. This is my second visit to this committee, having attended last year also to present at that time our third, and delighted to be back again this year. It has been an incredibly busy year for PCH, and what I'll try and cover is some of the big organisational stuff we've been doing, but also then focus more closely on our work here on the Isles of Scilly, if you don't mind. So in terms of the last year, our community hospitals, we have 13 across Cornwall and the Isles of Scilly, saw 4,725 inpatients. That represented a 9% increase on the previous year. And last year, you may recall, was an 8% increase on the previous year. And we're achieving that by actually reducing the average length of stay of patients. So in many of our community hospitals, probably 18 months ago, the average length of stay would have been 27, 28 days. Now, on average, that is down to around 21, 22 days. So we'll be able to see more patients. I have to say here on the Isles, we managed to create an interesting environment where the average length of stay is around about 5 or 6 days. And I think that's a credit to Anita and the team for that achievement. Again, across the whole of Cornwall and the Isles of Scilly, our minor injury units saw an 8% increase in the number of patients turning up for minor injuries. We therefore saw just over 96,000. To put that in context, that's about 20,000 people more than actually attend Treliske Hospital, albeit obviously many of those patients will be majors. They see around about 75,000. I know this year we've actually included the figures here at St Mary's, and we see on average between 3 and 4 a day. And I think for a hospital the size of it is and a population the size, that is quite a significant number compared again with some of our community hospitals on the mainland. I think the biggest increase in activity we've seen in the last 2 to 3 years has been our community nursing activity across the whole of the mainland and here on the islands. And last year our community nurses had 393,000 visits. Now, if you put that again in context, in 2011 when the organisation commenced, we were delivering around about 270,000. So you can see over this last 3.5, 4 years, there much more attention to supporting people who are much more dependent but living at home. And that's the right way. That's the government direction of travel, and that's very much what we've been looking to deliver. But as you can see, over that 3.5 years, to go from 270,000 to 393,000 visits is massive. And I know, Nita, you've seen an increase here on the islands as well. Our physios have carried out around about 90,000 appointments, which is fairly similar to the last 2 or 3 years. And again, that's consistent. Some of that's within hospital settings, sometimes in clinics. So overall, we had contacts with over 836,000 patients last year. Again, that was a significant increase on previous years. So very proud that we've been responding very positively to the needs of patients. Some key successes for the organisation in the last year. We were recognised by leading health service journal, HSJ, as one of the top 100 best places to work in healthcare. And I think, if you put this in the context of morale within the NHS being probably at an all-time low, we know our NHS providers on the mainland, staff engagement is certainly within probably the worst 20% in the country. For us to be recognised as one of the best places to work in healthcare, I think is a real credit to the staff. You will all know that over 55% of staff didn't want to transfer out of the NHS to a new organisation. And I think a credit, through the NHS staff survey, that staff have actually said, we ain't a bad organisation to work for. And that's an important asset for this organisation. Various awards last year, again, really important to emphasise that For example, Sharon Eustace was recognised by the British Journal of Nursing as Continence Nurse of the Year throughout the whole of the UK. We quite often, people not talk about an organisation like us not being innovative, not being creative. Actually, we try and do the opposite. We encourage particularly our lead nurses to take on new initiatives, and great to see Sharon recognised in that. We were also recognised in August, I think, as being the Caremaker of the Month Award, which again was a significant step for us in terms of nurses leading the way on the 6 Cs. We've received various other awards of National Quality Care in Diabetes. We've had, for the 3rd consecutive year, the Gold Healthy Workplace Award. And 10 of our community hospitals went through the Gold Standards Framework Quality for end-of-life care. We were the first community hospitals in the country to receive that recognition. The chair of League of Friends for Cornwall and the Isles of Scilly, Candy Baker, was recognised for her services to community hospitals with an MBE in the Birthday Honours. And we've won various bids. So one of our tissue viability lead, not only coming 3rd in the Journal of Wound Care, but she also won a £50,000 research project to develop through the Regional Innovation Fund to look at supporting patients at home with new pressure monitors. We were also one of the organisations that last year that received some money through the Prime Minister's Challenge Fund, and that was to develop an urgent care centre, very similar to what's operating out of West Cornwall, and we've been operating that at Campbell and Redruth Hospital. Campbell Redruth is our biggest community hospital and probably our busiest. It is also where, and John will be interested to know, that 3,000 patients are not registered with a GP. So it's an area that was very keenly, it's probably the most deprived area in Cornwall, and it was recognised as an area that we would really want to expand the opportunity for out of access to GPs. So we actually engaged GPs there from 8 till 8, 7 days a week. And the result of that was actually seeing a reduction of those patients potentially being referred on to Trelisk for x-rays, etc. And we saw that number reduce from about 7% to less than 2%. The sad bit of news on that is the money runs out in October, and at this stage we don't know whether that will continue or not. So overall, that's been a very successful year for the organisation. The highlight, I have to say, was our recent CQC inspection. It's not usually that people can say highlights and CQC inspection in the same sentence, but we had 29 inspectors planned visit in January this year, right in the middle of winter. They spent 4 days inspecting our services. In fact, around about 75 different inspections within that. So there was an end-of-life team, there was a children's team, there was a minor injuries urgent care team, a community nursing team, and also an inpatient team. So 5 different areas. And we were measured across the areas of whether we were providing safe services, effective services, caring services, responsive and well-led. So across those areas, we were rated as good throughout the organisation. I think what CQC picked up during that time was the commitment from our staff. I mentioned earlier that staff were uneasy about coming out of the NHS. It is a full credit and testament to the hard work of staff that we've actually received that good rating. CQC recognised it's not been the easiest of times for the organisation, that we have been financially challenged from day one, and there are still some significant financial challenges for the organisation. Most of you will know that we are now in the last year of our contract. The contract expires in March 2016, and at this stage we do not know what the Commissioner's intentions are with that contract. We're currently in negotiations on the contract price for this year, and we hope a decision regarding the future will be made shortly. In terms of I appreciate that CQC didn't this time come onto the island. I'm not surprised. It was January. They would say that actually they've inspected on many occasions, in fact, but they did carry out telephone conversations with Anita and others. And again, they fed back within the report the excellent services that they've seen and heard, and I think they also spoke to Health Watch, both on Cornwall and the Isles of Scilly, to get a view. We're really very, very pleased, and when the Secretary of State for Health came down recently, and he actually made the comment that a good report is not easy to achieve at this moment in time. So he actually genuinely said that was an excellent inspection you've had, and full credit to the staff. And I would publicly like to thank our staff for the fantastic work they do across Cornwall and the Isles of Scilly. And I think particularly here it is a very challenging environment, and you all know that we've had and still remain having problems in terms of recruiting staff. We've just now got a secondee from the mainland who's joined us this week, and she's going to be visiting all the B&Bs in the next few weeks. And it's something we are very actively looking at, about the potential to purchase a property, and we are in conversations with the Duchy about that. In terms of last year, our priorities last year were the 5 areas listed, which were around safe staffing levels, safeguarding, effective handover. Sorry, I'm going forward. This is what we're doing this year. Last year we're around the right place, the right time, the right skills, which was around staffing and looking at minimum staffing levels, particularly in terms of our inpatient wards. And that work has been completed, and that is part of the negotiation we're having now with NHS Kerno in terms of wanting to secure additional funding to getting the skill mix right. I wouldn't say we've necessarily across our community hospitals got the staffing numbers wrong, but I think we're seeing, as you probably would recognise, higher acuity levels within our community hospitals, and therefore we may not always have the right skill mix. And for example, our 3 smaller community hospitals on the mainland, we are now have just put in an additional healthcare assistant at night to satisfy fire officer requirements. And we've also successfully introduced a simple electronic rostering system. The second area was dementia. I think, that's something, an area that I know this organisation has been very proud of being involved in. We were successful in achieving some money out of DH, a joint bid with Royal Cornwall Hospital Trust, received 1.6 million between the 2 organisations to improve the environment. And I think that's very important, particularly where many patients will be admitted to Trelisk and then transfer on to one of our community hospitals, that the same colours environment go on throughout. Training for dementia is one of our high priorities, and again we're very pleased to see an increase in that in the last few years. Discharge planning, you won't be surprised to hear that Radio Cornwall often, and probably here, talk about black alerts and the system bed blocking, that horrible term we hear. We prefer to use the word delayed transfers of care, and I think the system and NHS Kerno particularly are leading at this moment in time, trying to work at more effective ways of discharge planning. Part of the difficulties have been around, certainly on the mainland, the difficulties with care home packages and home care, and that's something we're working very closely with our partners on. Reviewing patient pathways, again, our onward care team, you'll probably recognise that we work with 3 acute hospitals, so we work with Trelisk, we work with Derriford, and we work with North Devon, and all have very differing demands upon us, and we've now got onward care teams working in all 3 of those main hospitals. And the last was area of the 6 Cs that was put together by the nursing lead for NHS England. That's around commitment, care, compassion, competence, communication and courage. During our CQC inspection, apparently we added a 7th to that, which was can do. And I think, again, that is something we are, and I know we see that more and more, I think, here on the island, the sort of can-do approach that Anita and her team, there's a need, we respond, and I think that's something we share on the mainland as well, that we just get on and do it. So our priorities for this year are, again, around safe staffing levels, that we need to get that right. We use a Datix monitoring system, and we encourage our staff to actually let us know when things are not right from a safe staffing point of view. And I think at times, we don't always get that right. We recognise we need to do more. I'm very proud that actually, the duty of candour that's now in place upon NHS organisations, we've embraced that, and actually delighted to see our staff really using the opportunity to raise with the management of the organisation where they think things are not quite right. Safeguarding, we're active involvements in that. Many of you will know there was the Children's Review earlier in March, and we were actively involved. I think the report has only just come out, and there's some work that we need to do on that. Although predominantly we see adults, I talked about the 890,000, about 29% of those people come through MIUs are children and young people up to the age of 18. And we do need to do more on that. We do need to be more family thinking in the way we operate. And that's something we've taken on board. And we need to look at our website to ensure that we support that as well. The effective handover, again, is very much, again, working with our partners to look at how we can reduce the average length of stay further, but above all, reduce the delayed transfers of care. What we've seen in this last 12 months has been a significant increase in patients waiting for a package of care. If I said to you 452% increase, you might say you're overstepping the mark there, but that is the reality in terms of patients waiting in a community hospital for a package of care or a care home. Fourth area, integration, is flavour of the month, flavour of the year. Everyone's talking about it. Health and social care potentially coming together. We know the case for Cornwall at the moment is talking about one commissioner coming together. And obviously, that's an area that we're looking at very closely with our partners, Cornwall Partnership Trust and Royal Cornwall Hospital Trust, how we work more closely together. And fifthly, it's all about patients. That's what we're all about. It's about improving the lives of patients. So we're always wanting to do things differently in how we include patients. Delighted that last year our friends and family test, most of those people who responded said we performed very well. I know the work that Health Watch also suggested that most of our patients actually like the services we provide. So more closely looking here at the Isles of Scilly, again, I think, I want to publicly praise Anita and the team for the diligent work they do. And I know working alongside John and the GPs in terms of maintaining health and well-being for people here on the island. We came over recently and had a really positive meeting about how the services could integrate better. It always feels like we have a meeting that feels like months later we come back and revisit it. But I think we're very passionate that and we see those services being well integrated. And talking with Anita recently, when you had the gig rower recently who, was very close to death, I think it's fair to say, and how the whole system worked together and saved this gentleman's life. And I think that's what we're part of and we want to be part of. So we noted in the last year that we've seen an increased level of domiciliary services, which is hopefully going to significantly reduce our inpatient bed occupancy, and already it's down. I mentioned the Health Watch Isles of Scilly. The majority of the feedback has been excellent or very good, and we're very proud of that again. Mentioned CQC inspection. Recognise that there are some areas that I know you are very concerned about, and I think one has to be, and we all recognise, is the staffing issue. As an organisation, it has not been easy. We've not been able to, last year, offer a pay award because we couldn't afford it. We also had to reduce travel rates last year from Agenda for Change to HMRC rates, and I know people will say that's still quite comfortable, but it's, it doesn't feel like a level playing field. We know that this year we're still negotiating our contract, so we haven't at this stage been able to confirm a 1% pay award. The board have agreed in principle the 1% pay award, but we haven't been able to at this stage implement it until we've agreed the contract price. We would also now like to reintroduce the NHS pensions. Those of you will know that when we were set up, those staff that transferred over maintained their terms and conditions, including the NHS pensions, but new staff were not entitled to that. The organisation offered a Scottish Widows sort of stakeholder pension. Following a fair playing field review, organisations like ourselves are now able to provide the NHS pension, but actually we're not funded to do so. And that is a difficult negotiation with our commissioners at the moment. And we are finding recruitment more difficult. We're finding it more difficult partly because of that. We're partly finding it because the length of our contract is now March next year, and there's uncertainty over the future. And it's also incredibly competitive. For example, newly qualified nurses this year could join RCHT and receive a £2,500 upfront support, and then £2,500 a year later. We're not able to offer that at this moment in time. So we are struggling in terms of our recruitment and retention. What we do, though, is actually offer very good, in my view, very good training and support. And I'm delighted that 16 newly qualified nurses are coming for interview next week with us because they recognise the support that we give, and particularly the development opportunities. And I will hope that we are going to be in a position soon to actually announce the 1% pay award and hopefully move towards the NHS pension scheme, and maybe an extension to our contract. So we recognise that staffing is difficult, and Anita keeps us busy on that. I'm delighted that we have got someone now seconded in from the mainland, but it is an ongoing challenge for us, and I think you're right to raise, as you have done, those issues with us. We're also very keen to encourage less patients to have to go to the mainland, and I know it's always a debate, isn't it, John, about making sure the services are safe here. Particularly, we're doing a number of supporting patients with intravenous. I know there's been the debate about chemotherapy. We would love to see more patients supported here and not having to go to the mainland. That's something we want to work with you going forward. So during the last year, we've seen more community nurses doing acute care at home services for patients with IV antibiotics. 24-hour end-of-life care goes on, and through our community nurses, and that covers the outer islands as well, even if it is by boat. And I'm actually just really delighted at the services we provide. I hope you are as well, and I'm welcome to take any questions.
Thank you for a very full explanation. Could I ask the officers in the future to circulate printed hard copy of these long reports so that members at least have a chance to formulate questions? Are there any questions? Councillor Daly.
Chairman, I'm new to this committee, so I don't fully understand. Can the spokesman clarify for me what the organisation does?
We were established in 2011 by Cornwall Silly PCT, and we took on all the adult community health services. So that's community hospitals, district nursing, podiatry, physio, OT. We've got a subsidiary called PCH Dental, so we've got dental services as well. So it's really anything to do with adult community health.
Councillor Saville? Sorry, Councillor Daly, you've got to come back.
You go back, Colin.
Yes, so you get the bulk of all of your funding from the NHS, and you work out how to disperse it.
Sure. I mean, it was a block contract that was transferred to us in October 2011. So the majority of our money comes from NHS Kernow. There are little bits here and there from elsewhere, but most of it comes from NHS Kernow. And there was, at that time, there was what they call indicative activity levels. So, for example, we were expected to see around about 4,200 patients in a year in our community hospitals. So if we did under that, I think the Commissioner would be right to ask us, why are you doing under that, and probably want to take money away from us. What I was saying right at the beginning, that we saw last year 4,700 patients, so we're seeing much more than we were originally contracted or expected to deliver. And I think that's a credit to the organisation and what we've been able to achieve. Part of that, as I said, has been through supporting, reducing the average length of stay of patients within our community hospitals. Community nursing as well. At the time of starting up, we were delivering around about 270,000 visits. Again, if we were delivering less than that, I think John and colleagues in GPs will be asking a lot of questions. I think most GPs will recognise that we're, seeing more and more patients and supporting more and more patients to remain at home.
Chairman, if you'll excuse me, I've got one more particular question. When you're discharging from, say, Trelisk to a patient to go home, how do you ascertain what the facilities are in that home for that person to go to?
In terms of a patient at Trelisk, I mean, the expectation as soon as a patient is admitted, then a plan is started in terms of their discharge plan, their discharge date. For many patients at Trelisk, the automatic will be just going straight back home within a couple of days, with or without some support. We tend to support people with more complex conditions that may be at, say, Trelisk for 4 or 5 days and then need a period of rehab in a community hospital. We have an onward care team based within Trelisk, which will include nurses, OTs and social workers from the council. An assessment will be carried out, and then depending on the individual patient's requirements and needs and wishes, So, for example, it might be that a patient can go home, but they might need home care services, and they might need 2 people 4 times a day. So we will then try and arrange with those home care providers who sit on Cornwall Council's framework how soon they can provide that package of care for that individual. So when that patient then is declared medically fit by the doctors at Trelisk, we'll support that patient to go home. If it's to a care home, then obviously quite often patients' relatives will be involved in that assessment process. And again, negotiations will take place with that care home. The same really in terms of community hospitals. I mean, and, if we know someone needs to come back to, for example, here, Anita will be involved with the onward care team to arrange a suitable date for that individual to come in.
We do get, I think you're particularly thinking about off-island people, Colin, aren't you? And that extra bit of travel from Trelisk to St Martin's or Briar is actually exhausting. And where there may be a fall down is that the discharging nurse at Trelisk might not understand that. And what we tend to do is the relatives tend to contact St Mary's Hospital and speak to Ruth or myself and say, we're thinking of discharging Dad home tomorrow. It would be a really good idea, don't you think, they come into St Mary's Hospital for a couple of days. And we would also liaise with the GPs. And like today, I've got a phone call today. Could so-and-so come back to St Mary's Hospital? And we go, yes, we've got a bed. What we would ask is for a handover. And we would ask that person to provide a handover before that patient comes back. But I think the message is getting out that often people that have to go back to, after a period in Trelisk, being unwell, it's not a holiday, is it? You've actually been poorly while you've been in hospital. And maybe some time at St Mary's Hospital to make sure any package of care or any onward care is arranged, it's a good idea, and that's how we have been using St Mary's Hospital, and hopefully will continue to do so. So yes, they might be medically fit to be discharged from Trelisk, but they might need that extra intervention and time at St Mary's Hospital to get everything up and running for when they go home. And it's about a safe discharge. We do phased discharges at St Mary's Hospital. We're very lucky in that people can go home for half a day, a couple of hours, all day, and come back in the evening. We can't do that for off-island people, and therefore maybe people on the off-island will stay a bit longer in St Mary's Hospital. And that's a good use of our resources, and we should be using them like that. Does that answer your question?
Councillor? Sorry, Colin, I thought...
Yes, I'm pleased to hear that's the normal routine. I just wonder what effort is made to ascertain the home, their own home that the person's going back to, how that person can exist in their own home.
We should be involved. Ideally, they should contact St Mary's Hospital and say, or the rehab team at Trelisk that are dealing with that discharge should contact the community rehab team and ask for a home visit to assess that home. That is how it should work, ideally, a home visit. If Trelisk need to free up a bed, and they always do, ideally that person would come back to St Mary's Hospital, and then our local rehab therapy worker or the qualified therapy workers would come over and do a home visit. And because you can't do a home visit over the phone, you need to actually be in that. And that has happened 3 times recently, where someone from Cornwall has come home, gone to Briar twice, someone's gone to St Agnes, to actually say what that person needs in that home for a safe discharge. And if it's handrails or the equipment that Gareth and his team provide, that referral will go to adult social care. And actually, within a day, 24 hours, they send someone to the off-island and put rails in or whatever needed. Bigger pieces of equipment do take longer to get here, but we always have a store of what I call usual equipment available, and they are perch stools, Mowbrays, raised toilet seats. We can always provide them. And I must say we've never had an issue where we haven't been able to speak to Gareth and his team and they haven't been able to get handrails in, outside or inside, to help people get home. Does that answer your question?
Thank you.
It's not always perfect, I've got to be honest.
Councillor Saville, thank you.
Chairman, I just want to say something, and I don't want to reply. This is entitled Quality Accounts, Executive Summary. There's not one mention of the financial situation of Peninsular Community Health. If we have a report like this next year, I would certainly like to see some, not a lot, but some financial information. I listen to the press like everybody else, and I think it is, it is entitled Quality Account. I do not wish a response, Jim.
I will respond. If I'm in the chair next year, there will be a copy of the accounts as far as I'm concerned. Councillor Bennett.
Thank you, Chairman. I'd just like to ask, with the enormous, significant increase in the contacts with patients, either at home, outpatient or clinic setting or in hospital, is part of that increase, now up to 836,000, so on, due to a lessening of the time spent with each patient?
No, it's not. It's actually just purely demand. I mean, I think we all know the demographics.
They're different people.
Yeah, absolutely. Well, the 890,000 patients are not... They are individual contacts. So if we look at, say, for example, the 390,000 community nurse visits, there won't be 390,000 different people, because there are a number of people we will be visiting 7 days a week, but there will be a number of people we only see maybe 2 or 3 times a week, and only for maybe short periods of time. So, but what we're seeing, though, is more people, more dependent, and more people with greater acuity, I think, in the community
so
that need more
need.
That absolutely that need more intervention. That need more intervention from us. Yeah, absolutely.
And how do you explain that increase in need?
I think nationally there's an increase. You're seeing it all over the place. People living longer, people living with longer-term conditions. You know, when the NHS was formed 60-odd years ago, the average life expectancy of a male was probably around 66, and you died with one long-term condition. You're now talking about average life expectancy mid-80s, and people living with 2 or 3 long-term conditions. So I think it's just the progress that's been made, and that actually seeing that activity. But we're not the only, we're not the only organisation that is seeing that sort of increase, particularly in community nursing activity. Some of our colleagues in other social enterprises in Bristol and Swindon are seeing similar levels of increase, particularly in terms of supporting people to remain at home and not need an acute hospital admission. I think that's the key bit.
Thank you.
Councillor Davis.
Thank you, Mr. Chairman. I would like just to thank Mr. Jenkins for his report, a very thorough report. And obviously a lot of work's gone into it, and I'm very pleased to see that he highlights the staffing situation. I'd like to take this opportunity to embarrass Anita. I've seen her career blossom from when she first started. She's worked assiduously to serve this community, and her time is not... we'll eventually have to give up and retire. The time is coming when she won't be around, and nor will some of her very able lieutenants up at the health centre. We've been extremely well served at the hospital, and she's put in an enormous amount of work over and above for what she's been paid for, and she's keeping the situation going. I'm sure Mr. Jenkins recognises this. I know we say people are irreplaceable. She will be replaced, but whoever does it will obviously not be able to put into it quite what Anita puts into it, and I wouldn't want to leave this meeting without thanking her and pointing out about this committee the enormous debt that we owe her.
Okay. Any further questions? Are you prepared to accept this report? Those in favour, please show. Anybody against? It's carried. We now move on to item 7, presentation of quality accounts, Royal Cornwall Hospitals Trust. Who's doing this one?
Chairman, this is a video conference.
On?
A video conference.
Video
so
conference.
If you want to be able to be seen by the people, we need to just shove up a little bit because the camera's over here. So if you can change your seat and I'll dial in to the conference. If you want to sit next to Mary.
Yeah. Yes, we'll move.
Chairman, should we move on to item number 9 while I make some calls and see whether we can get them on the telephone?
We'll go on to item 9 until we can establish communication. Health Watch activity update. Carol. Could you turn on your microphone?
Taking me by surprise. It's here. As usual, the majority of our activity centres around medical travel, and the HOSC Medical Travel and Transport Group, which is a joint agency group which we co-chair with NHS Kernow. Later on in this meeting, they will be looking at an issue we've referred, and a little bit of background about that is that pending a planning review of all protocols for HOSC patients, which is a very good idea. Over the years, there have been a number of agreements made with various personnel at RCHT, and then they've got lost and forgotten, and there needs to be a written protocol. If we've got somebody in front of us from the HOSC, what do we need to do with them that might be different to what we do with anybody else? So that's excellent. That some feedback that we had in the survey that we did to feed into that review did highlight one particular issue around arrangements for people travelling without an escort who then may get stuck because of travel disruption, and what contingency arrangements may be made on their behalf. So we did ask for a separate meeting, a separate discussion about that. The reason that didn't happen is because RCHT are currently renegotiating their contract with Skybus. There's a lot of things that they don't know yet what they can and can't do. But we did feel that actually we needed to address this issue, and that's why we've referred it to HOSC. But otherwise, RCHT are present at the HOSC Medical Travel and Transport Group, and we're doing a lot of work with them ongoing. Did you want to say something about that?
Yes. This is one thing that we did refer. There are other things which we may have to refer. I'd like to speak to it when we get to item 11. But the whole point is that the question of the contingency plans, we have been discussing with them and repeatedly asking for meetings since last September. So I think it is time that some further action was taken.
Yes, one of my concerns is, as Director of Health Watch, there's always been the possibility, and I hope it's going down now, that somebody is discharged from the hospital on their own on the mainland, then they're taken to the airport, taken care of, and then they're left there, the fog comes down, and they've nowhere to go. It's one of the things which Jane has been attending to.
Yeah.
Jane.
This also applies to outpatient appointments where they're on a day trip.
Any questions?
No, I haven't quite finished.
Oh, sorry, Carol. not rushing. Go ahead.
Yeah, and the other thing on medical travel, on page 7, reducing the need to travel, and that's work that is ongoing with St Mary's Hospital and John as senior GP, supporting extension of remote consultation, but also I think in that is looking at what treatments can be safely delivered here. And I think RCHT at the moment are quite keen. They're coming over. Need to have a chat with both of you about that. But one of the things they'd like to do is look at what facilities you have and start thinking about extending the treatments that might be offered there. And the good news that all the work we do with the Medical Travel and Transport Group is that Skybus, HOSC Steamship Company, are represented at that meeting, and the Council of the HOSC, and hurrah, there is now a possibility of catching the 10 o'clock train from May to September, which is better than not.
Jane.
Yeah. The other good thing with regard to the Steamship Group is that we've been talking to them about the need to reschedule appointments if the weather looks bad, and they are actually making every effort to give a couple of days' notice if the bad weather is forecast, and I commend them for that.
Excellent. Carol.
I'll skip down to 424, mental health service provision. I'm so proud of this piece of work. It's delivered a lot already, and it was very much grassroots that a number of people who use mental health services came to me and very much had a lot to say and really wanted the ear of somebody to say it to. So we have organised a small group who have met with Gareth Peters and Fran, who's on the Cornwall Foundation Trust governing body, and Gareth obviously is leading on some mental health work, and have since met with John Garman and Gina Smith to talk about primary care. And they will be involved in the future in a sort of scheduled piece of work around patient pathways in mental health care. So that's all going to bear fruit. Our community survey, we've transcribed every comment. I haven't personally, so I don't know yet what it's said. I will read it and I will do my summaries and I will report in due course about the responses to the community survey. We're just thrilled that we have such a good response. And the signposting project, we're still working with the council around trying to develop an island-wide joined-up signposting service, the idea being that anybody you ask, if they don't know the answer, will know somebody who does and direct you to the right place. It's quite simple, should be easy. We'll have that done by next week, I expect. That was a joke. And that's the end of my report.
Thank you, Carol. Any questions? Councillor Daly.
Chair, it's a rather particular one. It says escort authorisation. Are there any sort of rules about whether someone needs an escort, or is it just taken on what people think?
The background to this, Colin, is that there are criteria, and that's down to the budget holder for the travel. And in the majority of cases, that is Royal Cornwall Hospitals Trust, and they administer the for some time there was no clear guidance to patient transport office clerks, and the demand and authorisation for escorts was very much patient-led, and that rose to practically half of all patients travelling from the Isle of Scilly asked for and took an escort. And I think it's fair to say that needed to be reviewed and looked at, and that is very much part of the planned review, what those criteria are, how authorisation is sought, who gives that authorisation, is it on clinical grounds, and what should the tick box criteria be, and what's the appeal process, and that's ongoing work.
Colin.
So if someone thinks they need an escort, do they just say that on the phone when they're doing their own booking, or do they need...
Yes, if you contact either Anita's team at St Mary's Hospital or Royal Cornwall Hospital Trust Patient Transport Office, you can ask for an escort. They will want evidence as to why you need that, and they will be looking for that evidence to be clinical. But in case of frail people who they may not need a clinical escort for the purpose of that appointment, but may have other needs which require an escort, then there's always the opportunity to explain that, and they will perhaps contact your consultant or your local clinician just to confirm that.
So will these criteria be published?
They should be. RCHT have been quite good about publishing frequently asked questions. We've got them on our website. We put them out earlier this year. I think they're getting much better at making that process clear, and part of the review will be better patient information.
Healthwatch have been promised that we will be consulted on any draft criteria when they come up with it.
Yeah. Any further questions? Councillor Saville?
Yes, Chairman, on that issue, I understand it has swung completely the other way currently, that many people are actually having issues actually getting escorts, being allowed escorts. So I think from being very open, as always, if things get, actually people don't use the system rightly, it does swing the other way. But that really wasn't my question. I was going to suggest, because I might not be here for the last couple of items, when you review the arrangements for vulnerable, unescorted patients, don't just home in on the steamship company part of it, because trains break down, other things along the journey, car accidents happen, it needs the whole journey looked at and not just this bit over the water. So that was all I was going to say. It's from Trelisk to St Mary's, really.
Any comment, Carol, on that? No. Any further questions? Is it your wish, then, that we accept the report? Those in favour, please show. Thank you. Is that system working now?
We'll try again. If we don't get the video conference working, we've got a phone conference available.
Yes.
That's okay. Go to phone. Hi Sally, it's Dan Marcus from Gaza City. You're connected now to the Health Scrutiny Committee. Everyone can hear you. I'll pass you over to the chairman.
I'm Gordon Billswell, the chairman of Health Watch. I'd like you to present... Sorry, that's wearing my other hat. Chairman of Health Overview Scrutiny Committee. Right. You have your report on the where are we? Presentation of quality accounts. Over to you.
National guidance, we've included updates on last year's
Thank you very much. Are there any questions members wish to ask? Councillor Bennett.
Hello, I'm on the shadow governing body of RCHT, and I welcomed your report, which seemed very positive, but that is perhaps a little bit contrary to reports being received by the governing body, which shows an ongoing increasing deficit and the delay of the status of foundation trust for the RCHT. Also, the general lack of good morale amongst the staff. And I wonder if you'd like to comment on that and perhaps the impact of the lack of foundation trust status on both staff and patients.
I'm not in a position or have the information to really answer that in full, but in terms of the quality account, in terms of the financial issues you raised, they would actually go to our financial annual account and the annual report. For the quality account, we're not expected to include that information within there. In terms of the lack of morale, I completely understand your comment. We try to reflect that sort of really with the staff survey results, and the listening interaction we're hoping will improve the morale, include engagement within that. In terms of the delays to the FT process, it's just going to be very open and honest with staff about our reasons for not progressing that at the moment. In terms of impact on staff and patients, I don't think that I'm actually qualified to really give a full response to that. I'm really sorry.
No, I do understand, but thank you.
Any further questions? Last chance. No, thank you very much for your report. Thank you.
Okay. Have you got any queries about midwifery service that you'd like to take back to the service?
Carol. Yes.
This is actually the next item.
Oh, sorry.
Next item. So if you want to finish item 7,
yes.
And then we'll move on to the next item, and Sally will answer questions about midwifery as well.
Okay, right. Right, we'll move on to item 10. Oh, midwifery. Never ending, I'm sorry. Sorry. Item 8, midwifery report from the Cornwall Hospital Trust. Okay. Sorry?
It's the same lady.
Yes. Hello? Are you still there?
I'm still here. I said at the beginning, unfortunately, nobody was able to retain someone's midwifery to talk to this item. However, if people want to ask me the question, I will relay that back to the service and arrange a formal response to that detail.
Carol?
Hi, Sally. It's Carol from Health Watch. We actually referred the issue of local midwifery cover, not so much about the service that you provide, but the level of service that is commissioned. And that was in risk, so it's probably not something we could deal with directly with you, because you are providing the level of service that you are commissioned to provide. But given the recruitment difficulties you've had this year, which is not just about housing, it's also about the nature of the post, we have asked commissioners to think about what they're asking you to provide and whether it might be reviewed. So I don't think it's a conversation we can have here, but it would be a conversation I think would be very useful to look at your experience of delivering the service, to look at patient experience, to look at the problems with recruitment, and whether actually it's a case for redesign. Having said that, the fact that you have maintained cover for 12 very difficult months, I think everybody recognises that you didn't let anybody down, and the patient feedback that we're getting recognises that the big problem has been consistency, and information, because there's not been one resident midwife here for that 12 months, but I think everybody's happy with the care that they've received.
Okay, that's good to hear, Carol. I will feed that back to the team just so that they're aware of what's happening at the moment.
Thanks.
Right, thank you. Any further questions? No further questions? Thank you very much for the information. Bye.
Okay, thank you very much. Bye.
Right, we'll carry on now. We'll go on to... Thank you. Item 10, NHS permanent update. Dr. Garman. Yes, on page 19, we do have a report here, a written one as well.
Yes, thank you. I should say, obviously, I'm here in my NHS Kerno role, which is as clinical lead for the Isles of Scilly. What I should also say is that until I've been doing that role for the last couple of years, and until the beginning of this year, I had 2 sessions a month to fulfil that role. Actually, at the beginning of the year, NHS Kerno realised that there were some quite significant projects that needed kind of fulfilling, and have increased my time up to a day a week now to spend on that. And actually, the council have also kind of matched that offer by allowing us a day a week of Gareth Peters' time to kind of join us on some of the commissioning projects that we've got ongoing. So I've given a very brief overview of the sort of commissioning projects that we've got going on at the moment, and they broadly fall into there are 3 kind of big strands that we're working on at the moment. The first is around enhancing some of the diagnostics that we have over here on the Isles of Scilly. And as you're all aware, sort of the first bit of that was about point of care testing, which actually has now been installed for just over a year, and it is actually proving to be incredibly successful. We had, I've kind of produced an audit actually, which I haven't included in this, I'm afraid, and I don't have with me, but it's shown that we've not only increased the quality of the service that we provide up at the hospital in terms of the acute care, but there's also been a significant reduction in the number of flyouts as a result, and actually it's therefore financially paid for itself really quite significantly. But the biggest improvement is about the quality of care that we have here, and actually being able to keep more people here on the islands, which is, and I think that's probably a reflection of the fact Steve mentioned earlier that actually our bed days at the hospital are down to about 5 or 6, and I think that is largely because a lot of what we do is acute care, and we're able to provide it safely and effectively because of the point of care testing. So that's been really successful. The second strand which we're working on is the X-ray. So obviously, as you're aware, we have an X-ray machine up at the hospital, and we have a radiographer who comes in once a week. But outside of that time, we have no facilities to X-ray because we don't have radiographers here. So we've been, this has been kind of a strand of work that's been going on for quite some time, and there's a lot of legislation to get through, which is why it's kind of taken, a long time to get here. But we're now at the stage where the 3 GPs here on the islands, myself included, and 2 GPs from Helston are registered with the University of the West of England, and we are kind of, we've started our training. We've actually got exams coming up next month, which is pretty horrific. I haven't done exams for 20 years, but in quantum physics, no less. So the training side is ongoing. We're kind of getting through our radiation sciences kind of practical, the theoretical stuff. We've then got the practical kind of aspect, and that's the bit where we are sort of in negotiation at the moment. So Trelisk are obviously providers at the moment, and they work within the regulations and have a kind of a formalised setup up at the hospital to do with the radiation regulations. The decision has been whether we, as there's a new commissioned service to provide urgent X-rays, which actually would mean setting up a whole new kind of radiation safety program, etc., or whether we plug into Trelisk and actually have Trelisk run the service from the hospital. And I think that's probably where we're going to head towards, is that the GPs will effectively have a contract with Trelisk to provide that service. but there's some. We're at the final points in negotiation on that at the moment, but it's not slowing down the training because we've already started, and we're hoping. Well, we were hoping to have the service up and running by about now, but actually there's been some delays on it because of all the issues around, just working out the contracts, etc. And I think we're probably looking into the autumn by the time we can realistically start taking X-rays. However, it's progressing, and we are certainly getting there, which is. It's taken a long time to get to, and there's been a lot of hard work from Alison Roberts-Davies on it. Robert Davis is on it. So, but we're nearly there. The third strand is around ultrasound, and actually that's quite exciting, this, because we now have an ultrasound service, a routine ultrasound service at the health centre. So once a month, Peninsula Ultrasound come over and they provide, anything up to 20 scans, but it's around about 10 scans a month we're kind of performing over here on the islands. In amongst that, actually there's been some ultrasound equipment purchased, and the second part of the university course is to actually undertake training to be able to take scans ourselves, so the GPs to be able to take acute scans. And Peninsula Ultrasound are helping out with some of the training and the governance around that. So we're just waiting for delivery, which should be any day now, of our ultrasound machine. So that, again, will probably be the autumn by the time we're able to start scanning, but that is also kind of progressing quite well. There isn't the legislation that goes with that, because obviously ultrasound isn't nearly as dangerous as radiation if you get it wrong. So that's a lot easier to work out, but we're nearly there with it, which is it's good. So that's the kind of enhanced diagnostics, and there will probably be a newly commissioned kind of contract to come out of that. Which will cover the three aspects. At the moment, the practice has a contract just for the point-of-care testing, but that's being looked at, and a new contract is being drawn up, which should be in place come the autumn when this all starts. So the second strand of the work that we're working on, and this is the work that I'm predominantly leading on, is around an integration project looking at all the services over here. So it's, Steve kind of mentioned it earlier, but really it's about integrating health, social care, mental health services, ambulance service are involved as well. And we're taking a very patient-centred approach to this. So we have a development board which has members from the council, from PCH, from myself. There's commissioners, so Alison Roberts-Davies from the NHS Kerno sits on that, and we've got Angie Turner from Cornwall Partnership Trust as well, so mental health services involved, and Steve Small from SWAST. But actually running alongside that and actually feeding into the development board is a clinical forum which I've set up, which is really where the main drive of this work is coming from. And it involves clinicians that are on the ground, and we're looking at very specific pathways of care. So the first one we've looked at is around the frail elderly, and particularly how we care for the frail elderly at night. And so the way we've done it is to actually have everyone who's involved in that pathway of care, so that will be GPs, nurses, social workers, carers from Park House, absolutely everybody in the room, along with patients as well, to really thrash out actually what it should look like. How should we be providing seamless care that isn't based on kind of organisations, but is actually based on a sensible kind of what is in the patient's best interest. And actually there's been some really interesting kind of things come out of that by having patients involved in the design of that. We've actually come up with some things that I wasn't quite expecting, but actually what we've then done is take that back to the development board and say, okay, how can we fit that around what we do, and how can we kind of make that happen? So as I say, we've started with a frail elderly pathway. There's also the mental health work that Carol has been started with a focus group, is then going to feed into this, and so the idea is that we will, instead of if you're looking at a patient journey, instead of having kind of organisations commissioned to do separate bits of that journey with kind of barriers between those organisations, artificial barriers sometimes, but there are barriers there. Actually, what we're looking at is smoothing out the whole pathway of care so that everybody is involved in it, and we'll work together. which is so we're kind of at the start of it, but it's seeming to work well at the moment. So the results we're getting are good. We will also be looking at acute care once we've but that will be the third strand of it. So it'll be frail elderly, the mental health pathway, and then acute care after that. But one thing at a time. In amongst that, I should say there are. We're also looking at things like paperwork and computer systems and how we can kind of interoperability between all of our systems, which is actually proving to be quite difficult because there are 5 different computer systems, none of which talk to each other at the moment. So there are some challenges to it, and I'm whether we manage to get through those or not, we'll see. But the third strand of the work that really I've asked Gareth Peters to come along and just kind of chip into is around the mental health crisis pathway, which has actually been is one of those areas where on Scilly, when something kind of happens, when there is a mental health crisis, actually we all roll our sleeves up and get stuck in and do what is in the best interest of the patient at the time. But it's never been formalised, and it's never been kind of actually thought through. Well, it's been thought through, but it's never been kind of commissioned in a way that makes sense, so that everybody knows in advance what they need to do. And there's been a big bit of work that was started 2 or 3 years ago, and actually Gareth has taken on the mantle of it, and we are very nearly there at signing that pathway off. So I might hand over to Gareth at this point so he can just fill you in.
Thank you, John. Yeah, no, we're nearly there, which is great news. It's an occasional event, somebody having a mental health crisis on the island, but as you can imagine, a pretty distressing event for the individual. And what we are keen to do is to try and avoid punishing that individual by them having to use a prison cell, which historically has to be used. If you're mentally unwell, you're ill, you're not bad. So that's involved a really good positive piece of work with the GPs, working with Anita PCH, with Cornwall Foundation Trust, with SWAST and the police. We're looking at putting in some changes to the room space to make a safe space up at the hospital that can be used. We can't promise that everyone's going to go to the hospital because it's not a secure environment, as in locked doors. There might be occasions when the police station is needed. The general principle actually is that we get people, the island wraps around the individual, that they have an initial assessment, that we link closely with CFT, and we get the person to the mainland as soon as possible, to where the specialist services are in places like Longreach for kind of full assessment. But sometimes, as you know, the weather comes in, as did happen earlier this year, actually. And I suppose we applied the principles earlier this year, and it worked very, very well. There's some additional kind of funding for this, so we're developing a bespoke training programme for a kind of multi-agency team that's going to involve adult social care. This is for children as well, so it's not just an adults pathway, it's adults and children. So children's social work teams, hospital staff, the SWAS staff, GPs, so that the pressure, so the responsibility if somebody is staying at the hospital for 12 hours or so doesn't fall on the nursing team, so they can carry on delivering the running the minor injuries unit and looking after staff without the because if someone's going to be there, they're going to need to have one-to-one care, and so it's going to be a bit unreasonable to expect. So it's good. It's a good cooperative piece of work from the team. So we're just there's a couple of niggles. One actually, just one last bit, just some discussions that we're hoping to kind of get out of the way by this week. Then I'll be looking. So the document's pretty much there. It's not rocket science really. It's just about everyone just being sensible and cooperating. But like Dr. Elmer says, you need to have something written down. You need to have a guide. So it's very much a working document, working protocol. We're using the opportunities to. The hospital's got video conferencing facilities. Cornwall Foundation Trust have got video conferencing facilities across their site. So there's the option of also some kind of video conference assessment as well. So I'm looking, I think if we can get things tidied up, I'm looking to really circulate that to the appropriate senior managers in the partner organisations for sign-off, hopefully by the end of June, I'm kind of aiming for.
Thank you. Any questions for Gareth or John?
Gordon.
Oh, Vice Chairman.
Thank you, Gordon. Gareth, thank you for that. You just mentioned your room developed as a safe place, but I thought I heard you say it wasn't sort of lockable or secure, but I'm just concerned that if it's not, and it may be, I might have misheard you, that perhaps somebody with mental health problems in the hospital could cause a bit of havoc.
I mean, that's certainly been one of the concerns all along, is actually how we look after people. And it's important to say there's a difference between a safe place that we're developing here and a place of safety, which is a formal legal secure unit where actually mental health assessments can take place. We're not aiming to develop that over here because actually we don't have the staffing, we don't have the expertise, and the number of times that happens, it would, yeah. So I think, you know, because the staffing levels at the hospital are such that actually you wouldn't be able to have one-to-one care, what we're then looking at is actually a separate rota of individuals who will provide one-to-one support. Actually, it'll probably be two-to-one support for that individual who's suffering the mental health crisis while we kind of arrange conveyance. And so.
Thank you. Councillor Bennett.
Thank you. I hate to sound so old and cynical, but a safe place has been talked about over the past 30 years, and there must be many written documents on the subject. I know, Anita, you've been there before, Dr. Davis has been there before, so I'm sure by now, I wonder what the inhibiting factor is. But I fear, like all things, it might come down to money. And on a wider subject, with the integration of care, social care and health care and so on, it has been put in place in other places, and usually the only reason for any failure of the efforts to really integrate services, which would be wonderful here, is funding. And I wonder what is the situation here with the financing.
If we take the question about the kind of safe place and the pathway, I mean, I first got involved in this about 3 years ago when I first arrived, actually as a result of a mental health crisis that happened over here, and we held a kind of multi-agency meeting to reinvigorate looking at the pathway. And so I got all the documents out that had been written, as you say, but the problem is that none of them have ever been signed off. There's been a lot written about it, but nobody has ever been able to agree what should actually happen, which is why it's always kind of failed to kind of get over the line in the last place. This time, actually, everybody is in broad agreement what should happen. And I think one of the biggest changes is that actually all previous documentation has talked about getting psychiatrists over here, getting Section 12 approved doctors, social workers, and trying to provide some of that treatment over here, which actually causes kind of a lot of logistical problems, and there are instances when psychiatrists have been stuck for Anita's giggling, but actually, if you think about it, a patient with a heart attack, you wouldn't fly a cardiologist here to treat them, so why would we fly a psychiatrist here to treat somebody who's having a mental health crisis? Actually, it's much more appropriate to get the patient to the specialist services where you have, and that's been the biggest change, is that actually we've looked at conveyance as soon as possible, as opposed to get people here assessed and then try and convey once, after a few days. So that's been quite a big change, and everybody is now signed up to that, which means that hopefully we'll get this one across the line, and actually we'll have a formal document of what happens if there is that mental health crisis. So what's being talked about before was having a place of safety. We're definitely not talking about having a place of safety, because that actually has a lot tighter regulations around it, and it has minimum staffing levels, and it has appropriate kind of mental health trained nurses, etc., which we simply don't have, and we won't ever have. So hopefully that answers the kind of first one. The second one about integration and budgets and etc., etc. I think what we're trying to do is firstly look at actually what things should look like. So how should a patient be cared for? What should those pathways look at? And so the purpose of having the clinical forum to kind of lead some of this work is to try and look at the clinical bit from the patient perspective and actually what should happen. We've then got the development board behind that who can then pick up the pieces of what the clinical forum says. But we deliberately don't have a vision of what is going to come out at the end of this. So, it could be a range of things from current providers signing up to a new contract, which kind of overarches everything. It could be that there's one provider coming out of it. It could be that some providers kind of join together. We don't know. We're actually not trying to second guess that at the moment, because actually that's where you start to fail. Once you run things entirely on budgets and you have an idea in your head of where you're going to get to, actually you're setting yourself up to fail, to my mind. Which is why we're trying to do this from a clinical and patient perspective, and then try and fit ourselves around that afterwards. So yes, there will be budgetary implications, and the vision is to have one budget covering everything. But it might be that actually we come up with something different depending on the work that's going on with the clinical forum.
Any further questions? No? Is it your wish that we accept this report? Those in favour, please show. Anybody against? Thank you. We'll now move on to item 11, single issue group, pages 21 to 24.
Thank you, Chairman.
Yes.
This issue's been referred to the committee by Us City Health Watch. It's about the contingency arrangements for vulnerable, unescorted patients when travel arrangements are cancelled. There's been some issues about whether there's anecdotal evidence at the moment, I think, whether people are refusing to take appointments because they're unsure about whether they could get back or not. The idea is to form a group to evidence gather, see whether this is actually happening, and if so, then try and make some initial findings whether we can actually get some arrangements in place.
It is proposed then that we form a small subcommittee or working party to deal with this. My own view is that we should form a subcommittee. I do not like working parties because this even excludes some members from attending those meetings. So, for a start, is it your wish that we form a subcommittee? It's on page 22. Jane.
Mr. Chairman, before we get on to that, can I just give a bit of background on this issue?
Yes.
It's something that Health Watch has been dealing with since last September, and I think we touched on it earlier on in our report. Basically, in our opinion, there has been a change in provision for escorts for vulnerable, or usually older or infirm people. We have been requesting a meeting with the commissioners for some time, and we've been unsuccessful in that, for whatever reasons, they're unable to have it until this, until that, until the other. We have put to them that in the meantime, there needs to be some provision for these patients pending a review of the whole system. They unfortunately seem to have difficulty around the fact that on a mainland appointment, there's a usual guarantee that someone will be back in their own bed with their own family overnight. They cannot seem to understand that, and we did ask them to come over here, but they haven't done. They can't seem to understand that people here don't have that guarantee. And we've had reports from people saying they're not happy. Because what's happened in the past is someone who's perhaps a little bit infirm, a little bit poorly, not desperately ill, but maybe someone that needs a bit of looking after at night, this sort of thing, or, in preparation for it, or can't walk very well, or can't carry stuff, has always been allowed an escort. Now, they've stopped this, and what they've said is, and this goes back to Councillor Savile's thing about the rest of the journey, what they've said is they will provide ambulance transport, which will pick them up at Land's End, take them to Treliske or wherever their appointment is, and then drop them back at Land's End afterwards, which is fine, unless flying's interrupted. And we've repeatedly asked, what are you going to do? What contingency plans have you got for these people if flying's interrupted? And they don't seem to have any. They say, well, they could get a bed and breakfast. But the whole point is if they need ambulance transport, they're not really up to staying in a bed and breakfast on their own. And this is the point we want to see addressed. Now, on this question of the subcommittee or whatever, Healthwatch doesn't refer issues lightly. We only refer them when we've really worked with the providers and we feel we've been getting nowhere and it needs a little bit of extra oomph. And I know this committee can require them to come and talk to us. The problem is, if something like this crops up, whatever you do to set up a working party or a subcommittee or even call a special meeting of the whole committee, what I would ask you to consider is the fact that if something like this crops up, it is fairly urgent, because all the time this is dragging on, people are still in this position. And I do feel that whatever you set up, it may be a better idea to, if something comes up and if the chairman and vice chairman consider it urgent, a special meeting of the committee's called. But I mean, that is up to the committee. But that would be my suggestion, to avoid delays and having to wait for it, by which time the issue is still ongoing and people are still being affected by it. Thank you.
Thank you. Councillor Daly.
Chairman, like you, I dislike working parties because the public are excluded. So I would like to propose, if we do form something, it's a subcommittee.
Subcommittee.
Just a clarification, the public doesn't have to be excluded from a working party. They can be invited.
I've been told that, but it's a very easy excuse to keep the public out, and I don't like it at all.
I'm afraid, impartially, I share Councillor Daly's views on this. Councillor Sims.
I'm getting the impression, I'm aware Healthwatch have done a considerable amount of work on this, and from what Jane's just said, you get to a point and then it stops. And am I right in thinking really that the function of this, and I think it will be a subcommittee, I think that's a much better idea, is to give you additional clout, really, isn't it? And on that basis, it has to be a subcommittee, because a working party has no clout, does it? So I would certainly support being a subcommittee.
Yeah, I think you can call a meeting of a subcommittee giving 5 working days' notice. And I think if we did this and we made a decision, it would have more clout, with all due respect, than Healthwatch does, because we are the Health Overview and Scrutiny Committee.
Yes. Healthwatch's remit is to monitor services.
That's right.
We have limited powers to actually, we have no power to require people to do things, but this committee has.
Well, I'd be prepared to use all the power it takes to solve this. So, is it your wish, then, that we form a subcommittee? May I have your views, please?
Chairman, before you do it, you'd have to consider what powers you wish to delegate to a subcommittee, that this committee wishes to give to a subcommittee. Because it is business that otherwise would be heard by this committee as a whole. You are then delegating to a subcommittee. So, A, you need a membership, you need to decide your membership and what powers you want to give to it.
Would we be allowed then to delegate powers to the subcommittee to take action?
The committee can delegate any powers that the committee itself has onto a subcommittee if it wishes to. It can't delegate any powers that it wouldn't ordinarily have as a committee, if you know what I mean.
So you could delegate the power to call providers to account. Is that?
If this committee has that power, then it can delegate that to a subcommittee, yeah.
Right, so the subcommittee could be given the delegated powers of this committee, which would save it coming back to this committee if action was required immediately.
Yes.
Thank you, right. Jane.
As I understand it, Chairman, this committee has the power in extremis to refer matters to the Secretary of State if they're not happy with them.
Good point. Right. Is it your wish, then, that we form a subcommittee, as suggested here in paragraph 4.5?
Propose that, Chairman.
Is that seconded? Councillor Davis.
What about the conditions about what can we make conditions as to how we proceed, the subcommittee proceeds? In other words, we have to give it powers.
It would have the full powers of this committee.
But can I make a proposal as to who that the responsible executive from the RCHT attends this meeting and explains in person what they're going to do about sorting the problem immediately? If we have another talking shop, it'll just go on.
Right, Andy.
If I may, I think you're better served having another special at this meeting, to be quite honest, because you then know where you are in terms of power, delegated power that you have, and you know where you are in terms of membership. It's open to everyone to attend, and you can...
A committee can normally delegate powers to the chairman and vice chairman, and there's no reason then why this committee can't delegate powers to this proposed subcommittee. I don't know why we're going into depth on it. Councillor Sims.
I actually agree with Andy. I don't think we already have a committee with all these powers. It's this committee, and this committee will actually, even if it's not in actual fact, it's got more powers than a subcommittee would have. So I would think you just make this a single issue that this committee deals with urgently, as opposed to forming a subcommittee. It is actually... It's an additional layer which is pointless, I think.
Mr Chairman, I fully agree with what Councillor Sims is saying there. The whole reason that this single issue group was suggested to be set up was to be able to deal with this item quickly before this committee met. But legally, apparently, we couldn't do that, so therefore it got referred to this committee. But while we're going all round the houses doing this, why don't we just put into motion a means whereby if something's referred and the chairman and the vice chairman consider it urgent, they call a special meeting of this committee and invite the relevant people to attend?
Yes, the chairman of a committee such as this, any committee, does have the power to call a special meeting. I've done it before on planning. Right, Councillor Davis.
Yes, I would support what Jane Hurd says from the Health Watch point of view. I think we need to do something immediately. It could happen tomorrow that somebody gets, more than inconvenience, but has their health damaged due to transport matters. Can we not, as I say, insist that the executive, whoever it is in charge of RCHT, attends this subcommittee before we go to the Secretary of State? If we go to the Secretary of State bypassing immediately, solving the problem, they will only throw it back. The central government wants us to sort these matters out here. There's no reason why the RCHT, who are commissioned to provide these services, should not provide the proper, correct services to safeguard the health of our community.
As I see it, surely it's going to be just as easy to refer to this. If there's an urgent item, it's referred to this committee, and I call a special meeting, and they make a decision straight away. All we need is 5 working days, and this would simplify the whole matter of selecting subcommittees and all that. It could come to this committee, and we'd take immediate action, call a meeting, and act. Colin.
Chairman, I'm inclined to agree with all that, so I'm quite happy to withdraw my resolution.
Right. Councillor Daly is proposing that these matters...
I think he just withdrew it, didn't he?
Sorry?
He just withdrew his proposal, I thought.
Yes, Chairman, I withdrew the proposal for a subcommittee in favour of this committee dealing with it urgently.
What you're saying, that this committee should meet urgently? Yes, well, is that seconded?
I shall second that.
Yes, it's proposed and seconded that items such as this, if they arise, are dealt with urgently by a special meeting of this committee, and this would speed things up. It would also have more power. Councillor Sims.
I wouldn't disagree with that. I think perhaps we could amend it slightly. This committee reconvenes as soon as it's possible to arrange the presence of an officer from RCT. If we formalise that, then it increases pressure on them to attend. And essentially, unless they're here, we're really still going around in circles again. So I would amend it. We reconvene as soon as it's possible with the relevant officer from the RCT.
Councillor Davis?
I would second that. It's pointless us meeting without having a representative who has the responsibility to provide services for the care of the health of our community. I think when this committee meets, there should be somebody who can answer questions and do something about it.
Jane?
Yeah. Bearing in mind that it may not always, this particular issue is RCHT, but there could be issues that are other providers.
So do you want other providers there as well, or just RCHT?
Chairman, is it not in the terms of reference of this committee anyway? We could have just dealt with it at this meeting, sure.
Yes. It is in the terms of reference.
Well, I think that's what I just asked for, really, reconvening in the presence of that officer, this committee, and I don't know. Now I'm just going to get confused.
Can I suggest that after this meeting, the people who've been involved with this so far decide who needs to be invited and who needs to be at the next committee meeting?
Okay.
Because it's not just RCHT, it's about the whole journey, as Christine said before she left.
Councillor Daly.
Chairman, I'd just like to add that I think we should ask for the physical presence of that person and not try and do it via a link, for two reasons. One, I hardly understood anything of what was going on with the earlier leak. The acoustics were dreadful. And two, I think if they have the experience of coming here, it might help their understanding.
Yes, I don't like these links, I must agree with you.
Precisely my point, Chairman, because we've been inviting them over here for a meeting since last September.
Councillor Davis.
One of the problems is, as Carol's just pointed out, it's not just the RCHT that people go for treatment, and they may be coming back from another trust who do not have the responsibility for the travel.
May well be. Right, now, are we clear? Have the officers got down what we are proposing?
I have that you want to set up a committee, a single-issue committee, as soon as possible, under the caveat that the people will attend who you need to attend, and that they attend in person.
Can I just say, my understanding is that it's this committee, as fast as we can, with a member of the, I can't say it, the RCHT here in front of us, or any other trust, because that's the point. But let's start with that person.
Yeah, and
as fast as we can. Let's get them on the
officers.
telephone this afternoon and get them here next week and sit here and talk to them.
That's proposed and seconded. Right, I'm going to take the vote on that now. You understand what we're voting for? Councillor Bennett, are you indicating or want to... Right, those in favour, please show. Anybody against? That is carried. Right, any further points you wish to raise on this? No. Now, there is an item which has sprung up, which is part 3. I do not see why this should be in part 3 myself.
Because it's about voting, it's about provision of access.
Chairman, someone could be easily recognised, I've been told. That's my understanding. I asked the same question, and I was assured that someone could be easily recognised. Should we start to have a... Not from the report, but from what might stem from the discussion around the report.
It would only be supposition. I really can't see, having read the Act, who's going to be identified here.
I think once we start, or someone could whisper it to you. I think it's probably the easiest way.
Yeah.
Andy, there is no part 3, is there? Oh, it's not. I haven't got it on my sheet. Okay.
Right.
We can't do that in open session.
Okay.
Yeah.
Right. In that case, we'll have to move into part 3. Do you have the... I haven't brought it with me. I didn't realise this was coming up at all. Yeah. Right. I want you to consider the following resolution, which I have to read out for part 3. That under section 100, A4 of the Local Government Act 1972, the public be excluded from the meeting for the following items of business on the grounds that they may be involved in the likely disclosure of exempt information as defined in paragraphs 2, part 1, schedule 12A of that Act. I propose that. Is that agreed? Right.